Evening, everyone. My name is Ivan Lopez. I'm a neurologist and a professor of neurology at the University of South Alabama in Mobile, Alabama. I'm certified in headache medicine by the United Council for Headache for Neurology Subspecialties, and it is my pleasure to host this session by the American Migraine Foundation regarding migraine prevention. And when do we talk about migraine prevention? We talk about migraine prevention when the headache frequency exceeds a certain number of headache days per month. And that number of headaches or headache days per month varies from one individual to the next. So, for instance, generally speaking, most experts will say that if the patient has 8 or more headache days per month, between 6 and 8, then most experts will recommend migraine prevention with medications. Now, if the headache frequency doesn't exceed that threshold of headache days per month, let's say the patient has only 4 headache days per month, then most experts probably would recommend to use acute abortive therapy, meaning medications to treat the pain only and nothing for prevention. Now, of course, that depends. So let's say that the patient having headaches says, I only have 3 headache days per month. The other 27 days of the month I'm headache free. I have these 3 severe headaches, but they are very severe. I'm in bed the whole day, I'm throwing up, I cannot do anything that day. My activities of daily living are severely impaired by these headaches. Therefore, in these circumstances, many individuals may elect to use preventive medicine or prophylactic medications because of even the headache frequency is not that high, but every single individual episode is very severe and disrupts the patient's quality of life, and therefore some patients with fewer headaches than 6 or 8 per month may elect to use preventative therapy. And for prevention, there are many ways, as we say here in the South, many ways to skin the cat. So the patient should try first, probably, depending on many circumstances, but non-pharmacological preventative therapies or options are a good thought. For instance, exercise. We know that exercise increases the levels of endorphins in the serum and in the brain, and endorphins have anti-nociceptive effect, meaning they're analgesics, natural analgesics that we produce in our body just by exercising. Another way of preventing migraines, for instance, would be to get enough sleep, not to skip meals, for instance, relaxation techniques. All of those have been shown to prevent migraines. One way to prevent migraines, if the individual is really disrupted by the frequency and severity of these headaches, the individual may try to avoid certain foods that the patient knows affects him or affects her in a bad way. For instance, if I know that eating, I'm going to say, Mexican food gives me a headache, then I don't eat Mexican food. That just makes sense. If hitting my head against the wall gives me a headache, then I wouldn't do that. Of course, it's a figure of speech, but I hope my audience this evening understands what I'm trying to say. A very common trigger for migraines is red wine or certain cheeses. So the patient will do well not to drink red wine or not to eat certain cheeses if he or she knows that doing that will bring a headache. So other than non-pharmacological therapies and avoiding certain triggers, we can also use pharmacological options to try to decrease the frequency and the severity of these headaches. And over the many years, physicians have been using what some people call hand-me-downs. Hand-me-downs means medications that are not specifically to treat migraines, but we have been using them for many decades and many years to decrease the frequency and the severity of these headaches, and that's what I'm gonna speak about next. Once again, for those individuals who just logged in, I'm Ivan Lopez. I'm a professor of neurology at the University of South Alabama in Mobile, Alabama. And today I'm talking about migraine prevention. Now, of the pharmacological agents that we can use, some of them, I'm going to speak first about the over-the-counter medications. We have certain substances that are over-the-counter, such as magnesium, a common mineral, vitamin B2, riboflavin, that's vitamin B2, can also be used to treat migraines as a preventative therapy. There is a substance called coenzyme Q10, and coenzyme Q10 has been tried in many conditions, Parkinson's disease and other conditions. And it has been also used in migraine prevention with some success. These over-the-counter medications, vitamins, minerals, have been used over some time, and the studies that have been done with very few patients, and therefore the studies lack strength. When we talk about scientific strength, they don't have much of that, but certainly they are an option. And I have had patients in my clinic, in my practice, that try magnesium or riboflavin or coenzyme Q10, and they get better. So these are options. When it comes to medications, prescribed medications, we can use basically three types of medications. And as I said before, they're hand-me-downs. And we call them hand-me-downs because they are not particularly designed to treat migraines, but they can also, on top of whatever they've been designed to do, they can also help to decrease the frequency of headaches in affected individuals. And the first group of medications include anti-epileptics. And there are two anti-epileptics that have been used over the many years. One of them is the valproex or valproic acid, and another one is topiramate. Brand names is Topamax, and the valproex is Depakote. And those two medications have been used for many years. They have been studied in double-blind, placebo-controlled clinical trials, and they have shown benefit in the prevention of migraines. Then we have also antidepressants. Antidepressants have been also studied in this setting, and we have basically two antidepressants that have been used over the many years. One of them is called Amitriptyline. Amitriptyline is a very old antidepressant, has been around since 1959, came to the market back in the late 50s, and over the many years has been shown to have some efficacy in decreasing the frequency and the severity of headaches in people who have migraines. The other antidepressant that has been used successfully decreasing the frequency of migraines is venlafaxine. Venlafaxine, the brand name is Effexor, belongs to a newer group of antidepressants that we call serotonin, norepinephrine, reuptake inhibitors. And I don't treat depression myself, but I know that psychiatrists, they prefer to use these newer antidepressants compared to amitriptyline, for instance, because the newer antidepressants have fewer side effects. They are not more effective to treat depression than the old ones, but they have fewer side effects. And therefore, they prefer these drugs. In my experience, both venlafaxine and amitriptyline have some degree of success in decreasing the frequency of these headaches, and most experts agree that these two medications have a role to play in headache prevention. So we have spoken about antidepressants and then anti-epileptics, and there is a third group of medications that we can use to treat migraines, and those are medications that we use to treat high blood pressure. And medications to treat high blood pressure, there are several ones, many. We have beta blockers, we have ACE inhibitors, we have ARBs, we have calcium channel blockers, there are many medications. We have alpha antagonists. All of these medications can treat high blood pressure, and many of them also can help decrease the frequency of headaches. The medications where there is the most experience is with the beta blockers. Now, there are several types of beta blockers, but the ones that work best for this condition, migraines, is the type of beta blockers that are not neither beta 1 or beta 2 blockers, but just beta blockers. And the one that has been around for longest is called propranolol. Propranolol is the one that we have the most experience with, and has been around for many years, for decades. And actually, it helps also to decrease the frequency of headaches in patients who have migraines. But it's not the only beta blocker that helps. There are other ones in the same category, and they also help. ACE inhibitors and ARBs are other types of medications to treat high blood pressure. And there have been several papers published in the literature showing that they actually have some benefit in some patients. Calcium channel blockers is another group of medications, but they have no real role to play in the treatment of headaches. Other medications to treat high blood pressure, like the alpha antagonists that I mentioned before, some of them may occasionally help. Now, let me also say that all of these medications come with side effects. And for instance, valproic acid, the Valproex, can increase body weight because increase appetite. And I don't use it in females because it produces, in some patients, produces what we call polycystic ovaries. And therefore, these individuals, they grow facial hair. And of course, I cannot know of any female that wants to grow a beard. And then they can gain weight, and they can lose hair on top of their heads. And so all of these side effects make valproic acid an unsuitable medication for most females that I know. And then topiramate can make you lose weight. And this can be a good thing depending on the individual, but also can make you forgetful. And then some patients may also develop kidney stones. So those are some of the side effects, and not everyone will develop those side effects, but some people do. Then the antidepressants, amitriptyline, can make you sleepy. So if the individual has a hard time falling asleep, then they can try amitriptyline. But the other side effect, important side effect of amitriptyline, some patients can experience constipation and dry mouth. And some patients may develop gain weight because amitriptyline can make you increase your appetite. Propranolol, on the other hand, also has side effects, and the main side effect of propranolol is it can decrease your heart rate. So if you are an athlete, if you like to work out, if you like to go for running, or if your loved one is an athlete, then potentially propranolol can decrease your heart rate, and you will perform poorly during your workout routine. And therefore, if my patient is an athlete and they play softball or they like to go running, then I don't prescribe propranolol based on that. Now, all of these medications have been approved in the adult population, and there have been a few clinical trials done in adolescents. For instance, valproic acid was tested in adolescents as well as topiramate 10 years ago, and the results were positive, meaning those medications showed to be beneficial in some adolescents. But in the younger population, like individuals below adolescents, at this point, we have nothing that we know of that can help these younger individuals. What we do, I see pediatric patients in my clinic, and what I do is I use the same medications that we use in adults, and depending on the circumstances and the individual patient, then I use those in the pediatric population. I offer my patients riboflavin, as I said before, and magnesium and coenzyme Q10, even melatonin, a substance that many people use to help them fall asleep. All of those are over the counter, and I offer those. I give my patients the option. And then if they prefer to take a prescription medication, then I use the same medications that we use in the adult population, knowing that we have no proof in the medical literature that these medications help these younger patients. Now, there are other things that we can do if medications by mouth fail to provide any relief. Then one thing that I do in my clinic, I do nerve blocks. And nerve blocks are injections that I give to patients over the trajectory of the greater occipital nerves that go in the back of the head. There is two occipital nerves, the greater and the lesser, and I usually inject over the greater occipital nerve, and I use a mixture of Marcaine, which is a long-acting local anesthetic, and depending on the circumstances, I may also use a long-acting steroid such as Kenalog. And not always I use the steroid, but sometimes I do. And then oftentimes this combination of drugs injected over the trajectory of each greater occipital nerve provides relief in some of my patients. And another thing that we can also use is Botox, and Botox has been shown in a large clinical trial done several years ago that it can reduce the frequency of headaches in patients who have daily migraines. And so all of those substances may be of assistance. Now, there is a new group of medications coming to the market, I hope soon. They are called Rpe Inhibitors, and there are different types. There are some of them are large molecules, and we call them monoclonal antibodies, humanized monoclonal antibodies, and hopefully some of them will come to the market soon. And then there is other group of medications, and they are different ones, and their names end with the letters GEPANT, Gepant, and we call them Gepants. And hopefully we will have some of those available on the market soon. I've seen many questions about medical marijuana. There are no studies done with marijuana in the prevention of migraines, and the only thing that we have available on the market out there is anecdotes. So somebody may say it helps me and it helps my neighbor, and that is not scientific. It is just an anecdote, and doesn't mean that marijuana helps. I'm not saying that it doesn't help, and I'm not saying that it helps. I'm saying that we don't know. What happens is that the FDA has categorized marijuana as a class 1 substance. That means that at this point, the clinical trials of marijuana treating medical conditions, it is not easy because the FDA does not approve of that. So we have to wait until studies are done, clinical trials, and they have to be double-blind and placebo-controlled, and therefore only then we will know. Now, so that's what I can say about that.